think I see. Okay. So I think I have to hit continue. So I think I see Genevieve, one of my colleagues at UCLA, the one that was asking about lymphatic massage. She is a lactation consultant there. And she in particular had emailed me today asking about lymphatic massage and the technique. So this is an opportunity to go over that, and then we can share the recording with anyone she would like to share with. So this is, let's see, whoops. Let me share my screen here. Oh, host disabled participant screen sharing. Could you enable me?
Let's see. Suspend, oh gosh, of course. I've never had to do this part before. Great. So I'm so sorry.
I can tell you, this is Genevieve. I can tell you how to do it.
Thanks, Genevieve.
So under the participants window, you want to hover your cursor over Katrina's name, and it should say more, and then you should say make co-host.
Done. Genevieve, thank you for saving the day. I appreciate it.
No worries. No worries.
Okay. So Genevieve, I don't know if you can see, can you see the screen, or are you just on audio?
No, I can totally see the screen, and I'm not showing my face because I took a shower. Sorry.
Yeah, Genevieve is the only reason why I realized this was at 6 o'clock and not 7. So, so anyway, okay. So, so Genevieve, I'm mostly going to just kind of be talking to you as, you know, because I know Genevieve and I have had some conversations about massage and, you know, people not harming their lactating breasts and treating it gently. So hopefully we can use this as a resource. So, yeah, so this is one of my favorite pictures that I use. I worked with breast physical therapists in my last practice, so they were breast specific. And this is one of them demonstrating a lot of techniques. And I love it because this baby was feeding on this other breast while this this physical therapist was doing this lymphatic massage here. So, so yeah, no disclosures related to this. So I'm just going to go over kind of breast and nipple pain, because that's obviously a big complaint with lactation, and kind of trying to help figure that out using some of these techniques. Lymphatic massage, which really I learned it as lymphatic massage, and I realized it's really lymphatic drainage. And so I've been trying to change my language, and I didn't catch that in here. And MLD is just I think probably the physical, and there's any physical therapy things I'm misstating here, please jump in, but manual lymphatic drainage, MLD. K-tape, kinesiology taping, I use that on occasion. It really sort of depends on the person. Neuromobilization is something that I don't do, but my last breast physical therapist was really, really good at this. And we use that a lot with radiation patients. And then cupping, which I think can be helpful, but it definitely has to be done right in breastfeeding. And it's not the same exact technique as we would use in, you know, keeping a cup on a certain spot. We want to gently move it around, which is basically approximating lymphatic drainage. And then therapeutic ultrasound, which is my absolute favorite. And Genevieve, I don't know if you guys would have in your lactation department, like an option to like help perform this under the supervision of OBGYNs, or like where your actual lactation department is housed. But for example, in my clinic, my nurse or my MA, honestly, even one of the other nurses has done this, and it's not hard to learn, but it's just more like you have to have it under, someone has to be doing it under the authority of a physician, or, you know, physical therapist, i.e. like someone that's sort of like trained with it. So
I think there's always options like that, but like anything, it's about setting it up and getting it all set up, and then training staff for sure. I'm dying to learn it because I'm very interested in the idea.
Yeah. And I think it's something too, when people feel like, okay, well, how are we going to help this mom with, a plug or engorgement? And people are like, but well, we have to do something. And I get it that like just saying, well, okay, ice. And, that seems like maybe you're not like doing as much, but it actually does a lot less damage than, heavy massage. And then the therapeutic ultrasound is just such a great thing to offer. And certainly physical therapy offices have this as a standard. And they've even studied therapeutic ultrasounds like chronic sinusitis. But it's the access to it that's hard for the lactating moms that, so anyway. And then this is just paper that this patient who was, this woman, Nicole, she was doing her doctorate of physical therapy. And this was sort of the culmination of her thesis. And then Ada Portman was one of my, that breast physical therapist I work with a lot. So we just kind of put together using techniques that we all know from breast cancer care and applying it to breastfeeding moms. So this is available. It's linked on my website also. So, when we talk about the breast and nipple pain during lactation and why, I use this illustration was done by someone I trained with, another breast surgeon who was a medical illustrator before med school. And so she has all these beautiful images that I think really help illustrate that the breast is not like something that should be squeezed or like really touched in any kind of way other than very lightly with lymphatic drainage, because, you have all these lymph nodes here in green and the super congested when you are lactating and pregnant, and then all of the nerves. So I think this this yellow illustrates the nerves. And I think, people are traditionally taught that, it's the fourth intercostal lateral branch, the fourth intercostal nerve that impacts the milk ejection reflex. But really, you've had a surgery periareolar and it changes everything. Well, the whole thing is the reason why the nipple is so sensitive and why it is so therefore subject to pain is that you have innumerable, all these interlacing nerves that come out from the intercostals, travel to the nipple, and then can shoot back neuropathic pain to deeper in the breast. And then the big thing is really these, the red is the blood vessels and the blue is the venous tributaries. And you get in there and you start massaging a breast like that, and it just inflames all the capillaries, it breaks them, you get all kinds of swelling. So and then this is just the same image, but just with the nerves labeled. And so really, again, it's very complex, and it's not just like one nerve goes to the nipple. And this is why people describe all that deep breast pain when they're having vasospasm, or, you have something else going on deeper in the breast and then it radiates to the nipple. And then this is just another from another friend of mine that sketches stuff out. And I always think it's kind of interesting to see people's different interpretations of things. But I also just like to reiterate, to everyone, I think Genevieve is aware we are the same listserv, but there's no scientific evidence to support the diagnosis of yeast as an agent of pain in the lactating breast. So, when I talk to patients about this, and I actually just saw a patient, it's like a daily occurrence, but yesterday, so commonly, mom had a baby that had the mom started to have like a lot of nipple itching and irritation, and then baby got treated for thrush, mom's been on fluconazole, and nothing, maybe got a little bit better because of the anti-inflammatory effect of fluconazole, and then it's still not better. So then she's, scheduling the appointment with me. And the first thing I ask is, are you allergic to any antibiotics? And she says, yes, like the macrolides. I was like, okay, so what did your baby get Zithromax? And sure enough, the baby got Zithromax. So I think a lot of these, this is where people, like the pediatricians that aren't necessarily from the mom side of things, they don't realize that what they're looking at on mom's nipple is dermatitis from an allergy and not yeast. Yeast doesn't occur on the nipple, occur on the areola, it occurs under the breast. And I'm sure, physical therapists see you know, heavier women with like larger breasts and under the arm. It's sweaty, you know, immunocompromised people, you know, diabetes, obesity. That's where, you know, yeast is going to occur in the, you know, an abdominal pannus and the folds there, but it just doesn't occur on the super highly vascular nipple epithelium. And in the breast milk, there's yeast, but there's also, you know, hundreds of millions of bacteria as well. And, you know, when we talk about, so, not just yeast, but so much of it, I say it's not just the latch, but it's positioning, because the latch fixes itself when you, a lot of times when you just position well. So you have a heavier breast and you know, have the patient feed lying on their side, the baby just clamps less at the breast. And then the pain is relieved. And, you know, people say, oh, but you know, you can't be lying down and breastfeeding forever. I say, no, it's not a forever thing, but like these that are really to just get them out of the pain cycle with all their engorgement and challenges. It's also just harder, I think, for new moms to like manage getting a small baby on there, and they have their pillows and like all this stuff, and it's just too much. And where you can just kind of simplify and lie them on their side on a table and take the weight off the breast. And really the other most common conditions causing breast and nipple pain are, you know, the oversupply or hyperlactation, and then vasospasm. We talked about that with the pain radiating from the nipple back into the breast. Subacute mastitis or bacterial mammary dysbiosis, that's sort of more analogous to like bacterial vaginosis. It's not contagious. It's just an imbalance of the flora that we see more often with like C-section births, hyperlactation, anything that changes the breast milk microbiome. Blebs are, you know, they present themselves on the nipple, but they're just a reflection of underlying ductal plugging and inflammation, just, you know, in almost like little biofilms lodging themselves on the surface. Dermatitis, honestly, I think is probably the biggest one. It's so common. And then also just, you know, hormonal changes with pregnancy and getting your period back and more sensitive breasts. And then there's something called, you know, I think probably you are familiar with functional breast pain, i.e. we have ruled out everything else that we could identify as a specific cause, and people are still having pain. This is, you know, an option where you can use PT techniques, support people, pharmacologic agents. I will say for like functional breast pain that we have no other source for, the SSRI class of drugs works like magic for stopping nipple pain and breast pain, particularly in the nipple, just because there's so much serotonin that's active in terms of receptors in the breast. I think you get some vasodilation out of it. You just get decreased sensitization of the neurons. So, and then, yeah, obviously the PT techniques. So that's what we're gonna kind of go over here.
Can I ask you, can you talk more about blebs? I've seen them on patients, and I know they like to pick them because they look like pimples, but I know that's bad. But otherwise, is there anything else to know about them?
Yeah, I mean, there's a lot to know about them.
Sorry.
Yeah, no, it's more just, it's exactly what you're describing, that people pick. There's stuff on the internet that's like, squeeze it out, but it doesn't make it any better. It just makes it worse, because it's like a surface. It's presenting itself when, you know, these are looked at under the microscope, they're just inflammatory cells. And so it's propagated through the nipple ducts. And remember, there's like millions of interlacing ducts. So it's reflecting inflammation in that ductal system. So it's like a narrow ductal lumen plus just some congested milk in there, but you're never going to make it better by squeezing it out or picking. All you're going to do when you pick is it just makes it more and more narrow. It gets more and more irritated. I mean, if you want to hear about blebs, my website, I have a link to an article that we wrote on blebs. Cause I've ended up like excising them after they've turned into hypertrophic scars, because people can pick like on a daily basis.
Okay.
It's such a problem. And then you also have people soaking their nipples in Epsom salt. And I'm like, I don't know where people came up with that, but you should soak a perirectal abscess in Epsom, not a nipple. All it's going to do is dry out and macerate the skin. So yeah, we treat blebs with triamcinolone cream, like a little steroid on the surface, and then lecithin by mouth to emulsify the milk and decrease the inflammation in the duct. But it really can be anywhere from like one bleb to bilateral blebs, different orifices. It can be really different in different people, but I also have people stop pumping if they're pumping, because that's such a risk factor. It's just non-physiologic breastfeeding. You don't get the bacterial exchange. And if there's any hyperlactation, I mean, certainly these like to present with hyperlactation or oversupply, so that you need to decrease that. But yeah, so this is, go ahead.
I just said thank you.
Yeah, so then this is just another, I have this linked on my website. I just think it's such a clear statement about how, yeast that people have in their breast. I like to point out, it's not contagious. Again, it's like a bacterial vaginosis. I can take even, like someone with candidal esophagitis and like stick my, rub it all over my hand, or if a baby had thrush, I could, rub the baby, which is also uncommon in breastfed babies. I mean, that's a whole issue, unless they're really premature and, in the NICU, immunocompromised, they are, generally healthy babies, like all the bacteria in breast milk is going to protect them. And anyway, the point is you can like rub your hand on yeast and it's not going to give you a yeast infection. You can have, sex with your partner with a yeast infection and you're not going to get yeast. It's not like gonorrhea or herpes or something. I am not sure why that image is missing, but sorry. So just the pain cycle, you get engorgement, then that starts the nipple pain, and then you are struggling with positioning, and then that affects the latch, and then you get trauma, and then you end up with vasospasm. This is engorgement management, reverse pressure softening. That's something, where you just gently, hold some pressure, very, light pressure against the areola. There's no subcutaneous fat behind the areola. So so you can, help make the nipple more erect that way. You can also remove a very small amount of milk before getting the baby on the breast. I always say, people can do like a little hand pump, just to kind of get some of the edema out of the nipple areolar complex. And then sometimes, we traditionally say to sandwich the breast, but sometimes if people are so engorged, I actually get like right next to the nipple, and like hold the areola right next to the nipple. And that can make the nipple more erect. Because it's, the nipple's erectile tissue. So you can, stimulate it if you get enough of the edema out of the way. And then positioning, if you can do laid back, this is one of my friends from residency, like putting a baby on top in the laid back position, that's helpful. But I also find sideline is just easier for people to manage sometimes. And then I generally say ice, but I also like tell people if heat makes you feel better, go ahead and do that. But ice is going to be the most beneficial. And then lymphatic massage or drainage. And then again, the functional breast pain. So, the exclusive pumping, that's such a risk factor. Part of it is a disruption of the microbiome. And then the other part of it, I think, is just, the depression and anxiety that can be associated with that. But, you end up with patients, this is a patient that was, pumping this right breast, feeding off the left breast. You can see she was actually more stimulated on the left, but still pumping on both sides, just had like a massive overproduction of milk. And in our literature, they talk about propranolol, which I just don't think that it's what I want to give breastfeeding moms. It makes people really tired and headachy. Sertrazine, the antihistamine class, I think that's probably at best, like, going to relax them a little bit because it's antihistamine, it's a little bit sedating, but there's really no reason why sort of functionally that should work. Neurontin, is reported in the literature. And that's something else I don't love to give, or really at all like to give breastfeeding moms things that are too sedating. Even though you have some tolerance to Neurontin over time, it's still something that I feel like it's more like treating the end neuropathy rather than the SSRI class of drugs, which really treats receptor level, dysfunction in terms of serotonin, as well as some of the overlapping anxiety and depression that can occur. So deep massage causes tissue damage. So I've really decided over time that lactational abscesses and even some mastitis are actually completely iatrogenic. Like, I think that if in my practices, in New Mexico, and then when I moved back to California, I started out with a much higher abscess rate. And then as I gotten to know people in the community and, people get triaged to me earlier, and the OBs, have the breast patients come to me, and we stop, we get someone that has an early mastitis, and I have them stop pumping, stop overfeeding, have them ice, don't have them massage. And the abscess rate has gone down over time so much to the point that I don't really very frequently ever deal with that. Because you're stopping the problem before it starts. But you get someone with like some overproduction, and then they keep on pumping to empty, they just back up more congested lymphatics and capillaries. And then, there's all kinds of, tissue necrosis from massage as they're trying to squeeze it out, and then eventually just coalesces into an abscess. And it's really, I think people think it's like congested milk, but it's really just inflammation. And then, you have some background of milk in there, but it's really the tissue injury that's the most problematic. And then I also just remember, like, when I look at breasts operatively, I always am thinking like, how do people want to massage this? And I try to take pictures that I'm still not really sure I can illustrate what it really, breast tissue. And I would say it looks like calamari, and it feels like calamari, except it feels like really tough calamari. Like, it's not like a good, like fresh piece of octopus or something. It is like a frozen calamari that is like over fried or something that's just tough. And like to think that, so when people think like, let's just say that this is a mom that had, been breastfeeding, like, you're not looking at, even intraoperatively, like a breastfeed mom, like I'm not looking at milk. I'm not looking at ducts. I'm not like, unless something was like pathologically obstructed, it's just, we're looking at just white tissue. So it looks just like a thyroid. It looks just like a pancreas. Like, you're not seeing all the little ducts of the pancreas or the ducts of the vessels in the thyroid. You're just looking at like solid organ. And then also too, this is, an example of a lactating patient mammogram, just like extremely dense tissue. Normally in non-lactation, we see people, it's like mostly black. Like, we want to see a mammogram that's mostly black, and this is just like a whiteout. And so just to get back to the massage, so if anyone is getting massage, this is what happens. So, and I actually just saw someone that had major hyperlactation, and she wasn't super reliable, I guess. And she was listening, her mom, was telling her, you have to massage. And I, and then the OB called me, he was like, she has a big abscess, and he's like, I don't know what it is, like a big mass. So he sent her over, and I look at it, and it was what's called a phlegmon. So a phlegmon is just a mass. Like, this person had a phlegmon right here. This is not, if you look at it on ultrasound, this is the ultrasound here. It's indistinct. Like, if you see an abscess, it's going to be all black. But this is like a bunch of just, like, there's some milk in there, there's some just, it's basically tissue edema, just inflammation. And so you can either, if you keep on massaging, keep on pumping, it's eventually going to turn into this. You're going to cause tissue injury. But this is a stage before it gets to an abscess. So this is someone that I had her stop all the pumping, and we decrease the inflammation. But if that goes on, that's going to turn into an abscess. So this is an illustration I used. Whoops, that's from a recorded presentation. Whoops. This is an illustration I used to talk about to like try to help people conceptualize why you shouldn't massage and how you can actually help relieve congestion, because really, like, quote unquote plugs are really just like congested lymphatics, congested vasculature. Yeah, there's some milk in it, but it's not like the driving force. It's just like all these cells that are just hyper metabolic. So if you imagine the duct of a breast is like a bridge, so you have and let's imagine that the water around it is the edema. So you have all these millions of microscopic ducts traveling through a big river of edema. So you either need to, in order to get more cars through, you need to decrease the amount of water on the bridge, surrounding the bridge, and make the bridge wider, or you need to reduce inflammation on a ductal level by treating, for example, subacute mastitis or dysbiosis, or just emulsifying the milk. With the lecithin does kind of both of those, but sometimes you do have to otherwise kind of address microbiome issues. So again, it's like either making the car smaller and more able to pass through, this narrowed ductal lumen, or the big one is really decreasing the water surrounding the duct and just having everything open up and be more comfortable. And so this is, manual lymphatic drainage. And it's really quite simple. And I mean, if you want to jump in, because really this is like what I've learned from my physical therapist and in training, and I didn't come up with this. But this is how I teach it to patients. And again, the other breast surgeon I train with, she is the one that did these illustrations for me. So the way I learned this was like my old physical therapist said, light traction, like petting a cat. So brushing, and then she called it opening the doors. So, just the very light circles here at the junction of the subclavian and internal jugular. And so you do those 10 small circles there, and then 10 small circles in the axilla. So just light drainage, or light, just gentle stimulation to let the lymph nodes know you're gonna drain them. And then you just take and you sweep. So, and sometimes if I have a patient in the clinic and we're talking about other stuff and she's just like super engorged, like day 5 postpartum, you can just brush. And it's amazing how much just like with brushing, you can actually see someone get relief like within, the time that you're talking to them. So it's just literally like brushing. And then I will also tell people that, people, I've had people just tell me that they like to do it in the shower with like soap or whatever. But I think part of it is that you want some of the traction, like you don't want it to necessarily slide that easily. You want to get some traction on the skin, because that's what lifts the skin off the underlying lymphatics. Mm-hmm. But I just think and anything you can do, I think, to kind of like redirect people into something that is helpful rather than something that is harmful that they can be doing. And if moms are feeling like, oh my gosh, they're just panicking and they have all this like congested, their breasts are just like, they don't even recognize them anymore, that can actually, people can end up doing quite a bit of that. And I'd rather have them, like, you can't overdo that, but you can totally overdo. I mean, I've seen bruising, like I said, phlegmons, abscesses. So
can I ask a quick question about that? So I remember from like old timey La Leche League conferences many moons ago, them recommending using like a baby brush.
Yeah.
And using a baby brush just to gently like move around in circular motions around the breast, and to sweep either from the axilla towards the nipple and then away from the nipple. Would you say that, I don't even remember why I remember that, but because it was more than 10 years ago, but But it seems like that might be because it's soft bristles. It would just, as long as they're not jamming it into their breast.
Right.
Yeah. In the lymphedema world, we do sometimes have patients do lymphatic massage with a dry brush.
Yeah.
Which is the same idea. I think I would continue just to go away from the nipple though, towards the axilla.
Yeah, I think that's where the lactation world, like that's where that disconnect is, because Jenni B, you're probably familiar with like the therapeutic breast TB and therapeutic breast massage and lactation.
Yeah, we all teach it.
Yeah, it's like it's like the best approximation of, like, it's a little more gentle than like some of the other things you hear about where people are just like trying to squeeze. But so that's like a little bit of hand expression. And I think maybe but even still, it's like there's no reason to brush towards the nipple. You want all that lymphatic congestion to, 90% of the breast is drained by the axilla.
Right.
So you want to just get that you want it to move out. So yeah, I mean, that's exactly where the lymphatic massage it's lymphatic drainage. And it's
no massage.
Which is why I think I also, it's people are like, oh, well, what about, it's like, it's actually drainage. And that's why it's called, MDL and and I think it's sometimes hard for people to understand. I mean, I will just say, as a surgeon, when I first saw this in like, we do like a physical therapy rotation in our fellowship. And I was like, what is this? Like, they're just like barely, as a patient with like arm lymphedema, I was like, what are they doing? This is so weird. And only after I think I did it myself in practice with breast lymphedema that I realized, and how much, if you're just doing it and, talking to a patient, and, I think it kind of also is like a good time to like just offer relaxation and like some talk therapy.
Relaxation too, technically in lymphatic school, and I think this is where there's like the art, and it can work more ways than one, but they traditionally have it a little bit more slowly, in which is I tend to be fast, so I have to slow myself down. So I mean, you can certainly do it in that quick way, which seems obviously you get results doing it that way as well, but maybe for someone who is really up here, to have them like do deep breathing slow might just kind of even chill them out a little bit more.
Yeah, I think when I do it like the brushing, I think I'm in my mind, I think more of like the baby brush, like you said, is actually the right idea. But yeah, you're exactly right that it's like the slower, more relaxed. Yeah. Good point. And this is just a schematic of like, this is that physical therapist of mine, showing how she was just kind of stabilizing the breast, and then that like gentle lymphatic drainage there. And then again, this is like that alternating with hand expression. And I think that's fine, the hand expression part. But I think like their videos of that, it's a little too rough for me. So yeah.
I agree. Because they do, and they actually say the words, they put their knuckles into the breast and they say,
yes,
they say knead the breast. And I always say, we want to jiggle the jello, don't knead the bread.
Yeah, exactly. Because anytime it's just like, I think I explain to patients is like, you're not going to, if you twist your ankle and it hurts and there's like all kinds of inflammation, you're not going to massage it. It's going to make it worse. You're going to ice it and, elevate it and treat it gently. So, and so then, gestational gynecomastia, this is something I used to see a lot of in Tanzania. It tends to affect more like African descent patients, but it can progress to, to like go from this like really large, edematous breast to, necrosis if the edema isn't treated. And then this is another one of a patient that I like to show that it's just like, you can see the bra marks there. And then even the edema from like the bra was like cutting in there, and then just all of this edema. So, this is an example. That's from another recording. Sorry. It's an example. So then dependent lymphedema, this is where we see, this is a mom that, had a reduction in the past. You can see she has these incisions from her reduction, and then just had like huge amounts of breast growth in her pregnancy still. And so you obviously, it was like a little more pinkish here in the under part. And this is a surgeon friend of mine. She had she had punch biopsy, because it's like never wrong to biopsy something if there's any kind of concern, but really like the big picture of this, it's symmetrical, it's this light pink. And if anything, I'd say the best thing to do is to have the patient do lymphatic drainage for a week and then come back and see how they are.
This is just,
oh, that was another, sorry, I'm not sure why this is, I think I had copied some slides from a different presentation, put them in here. So Genevieve, this is actually that patient that we shared that taken care of her in her first pregnancy. And this was someone that had that, really extreme breast growth. This is during her second pregnancy, but you can see she had even developed this like chronic pitting lymphedema. So it's like, this was not even really responding to lymphatic massage at that point. And it's kind of like chronic lower extremity venous insufficiency. And they just get these chronic pitting. But she certainly was in better shape than, she could have been, I think, without any.
No, in her first pregnancy, her nipples became concave. So those nipples, they said, oh, the nipple's inverted. And I said, what do you mean? They said, oh, previously they were everted, but now they're inverted. And I was like, those aren't inverted nipples, those are concave nipples.
Yeah, just from all the surrounding edema.
Yeah, it was really crazy.
Yeah. So then K-tape, I don't I will use this sometimes. It really kind of depends on the patient. And sometimes I worry about like tape allergies and just like really bad engorgement. And it just like almost like making the skin more sensitive. But if people have used K-tape on other parts of their body, some people really like it, then I will, offer it. But it's probably not something I do very frequently. But it's really easy to do. As you guys know, you have the tape there and the tape here, and then you kind of wrap it around. And then, you have to leave space for the infant. And the idea is that you're kind of like draping it and not like constricting the breast.
On that K-tape, I have I'll send it to you, a poster board from another PT who increased milk supply with K-tape.
Yeah, I've seen that. My there's some physical therapists I work with in New Mexico that also did that. Like that's kind of like what they reported with the milk increase. And I don't know if that's just like, it's hard to know why. Like if it's I don't think the K-tape itself is like making the receptor level cells make more milk. I think it's more that it is possibly draining some edema that was, just making things congested. Oh, there was my alarm to remember to log in with actually, an hour earlier. So sometimes, I think it's probably not like the only key, but is probably something like playing a part in, different stimulation of the like maybe congested capillaries. So the other thing that, again, I don't do this myself, but I've seen the physical therapists do this, and you guys could probably speak more to this, of the nerve mobilization and how that can really like decrease some of this nerve pain that people get from just like engorgement and just, nerve entrapment. And then I think I probably need to move along here. And then, so you're basically, as you know, like manually palpating this nerve. And I mean, I can't do this. My physical therapist could just like get in there on the rib, and it worked really well. So cupping is something that I think this is when people are told to put a haka on their breast for a plug. I think this is kind of what the person who came up with that idea is trying to approximate, but the whole idea is that the cupping, it's a really gentle cup and you're lubricating the skin and you're moving it around. So it's basically like lymphatic drainage. You're not just taking a cup or a haka and putting pressure in this one particular space. And then, of course, therapeutic ultrasound, it's so great. I love it. Just solves so many problems. It's so helpful, mostly with the reduction of pain and the reduction of inflammation. And then I just have this image as, the settings that you use, that it has been studied. I think in the United States, certainly physical therapists use this, but worldwide, especially in Canada, Australia, Europe, really everywhere but us, physicians use it a lot more. And it's just, I think there's a good place for this in lactation for sure. And then, I always tell people don't pump because this is what happens. This person, this is like the outline of her. This picture doesn't even capture the amount of engorgement she had from she was so congested, and then she just kept on pumping, and it just backed up all of this, obviously milk, but if you see all this vasculature, everything's just inflamed. And this is an example of someone that, people will come in, and if this person was calling the triage nurse, they would get antibiotics over the phone. And this is the kind of person that I see, and I say ice, Advil, Tylenol, some therapeutic ultrasound, and it makes it go right away. And yeah, if you're thinking that there's again, this is an oversimplification for sure of the ductal system, but the idea is there's some inflammation in the duct. You have some milk backed up behind it with all kinds of lymphatics congested as well. And then I always like to share this honestly in so many different things that I talk about, because perinatal mood anxiety disorders overlap so much with lactation. And it's the most common complication of pregnancy and childbirth. And, breastfeeding complications increase the risk, but it's also what's the chicken or the egg? Because very often you have a mom that isn't in a great place and is either depressed or anxious. And that's kind of leading to breastfeeding challenges that wouldn't necessarily exist without that. And I find so often that the expression really can be with pain. And we know that even PMADs in general, people present with postpartum women, present with symptoms that are not necessarily saying I'm depressed, or it's often insomnia, pain, somatic complaints. So people that are really obsessed with pumping and can't stop, that's, something to be concerned for. And so this is my information if anyone needs to get in touch. And this is my website that I'm working on some of the links and layouts to, but the content is here. So I'm just tweaking it a little bit this next month. So the physician guide to breastfeeding.org has my information.
Can I ask a question? Yeah. This was amazing. Thank you so much for being here. But one question I had in lymphatic world and lymphedema world, we learned so much that one of the most important things for dealing with inflammation, meaning swelling, not the chemical kind, is compression. I'm wondering how often you prescribe a compression bra to the women and if that's been helpful.
Yes, that's a really good point, and that should be included in this, I realize. I constantly am telling people, do not walk around with your breasts without a bra. You need a super good tight sports bra to decrease some of that. And I think that's also something that the breastfeeding world doesn't necessarily, the number of women that are told to air dry their nipples or not wear a bra. And it's the first thing I just explain it it's like being on an airplane for 12 hours and you're and you haven't put your feet up at all and they're swollen and they hurt.
Okay. All right, great, thanks.
I think it's probably a balancing act between sometimes their nipples hurt, and so sometimes breast shells are helpful so that they can wear a well-fitted bra. so that they have some space between their nipple, but then they get edema in their nipple because they're now wearing a breast shell. And so it's a balancing act between, well, how long can you go without wearing a bra so that you don't have anything touching your nipple? And how long can you go wearing a bra, but need to avoid having nipple edema? So how long, like there's just a balancing act between finding comfort when everything feels uncomfortable.
Yeah, that's where if like people are really that hypersensitive with their nipples, I often will prescribe a steroid, like a triamcinolone cream, just to like reduce the hypersensitivity. And that's why Apno, works when people are told to get that, because it's a steroid in it. So I'll often do like a steroid cream, or have them get, instead of the shells, because the edema is such a problem with the shells, like a organic balm, and then just use the gel soothies that are, if you use a balm with them, they're not as sticky, and then people can like heat them up or put them like in the freezer, and then you don't get the edema thing. But yeah, a lot of it's just the overproduction too.
Right, it's just getting that swelling down.
Yeah.
If it's just engorgement, or if they're having some kind of secondary engorgement experience.
Yeah.
That makes sense.
So speaking of, because one of my questions is, we've been taught to teach women hand expression, and there's a lot of women who are actually interested in antenatal milk expression now, because we just have a lot of mothers with gestational diabetes, and they've learned about antenatal. And so we generally talk about like therapeutic breast massage and hand expression going in hand, but it seems to me like we need to rethink how we present information. Like if you're going to do antenatal milk expression, and I don't even know what your thoughts are on antenatal milk expression in this context, but I mean, let's start there.
Well, I mean, I think that the thing is that a lot of these moms with diabetes, it really depends, because I've seen diabetes present like actually like breast growth and tissue edema, but not really very good milk production. So that's someone that you would be wanting to do lymphatic drainage with. But the more average, I think, circumstance I see with diabetes and gestational diabetes and is that people have like larger, kind of like less engorged breasts, that I wouldn't actually be doing lymphatic massage in, and they would just be people to like talk to about hand expression, if that makes sense. Like I'm thinking of like the breasts that I more commonly, I think you see these like not so, you get that engorgement in people that aren't necessarily going to produce milk. It's like it's just like an interstitial edema kind of thing. I don't know if that makes I'm trying to think of a better way to say that. Like, I guess if you're not seeing a lot of like dependent lymphedema, or like a breast that's uncomfortable, that you could just teach hand massage or a hand expression without the lymphatic drainage part of it.
Did we lose Genevieve? Oh,
I don't know.
You're muted if you're.
Sorry. So hi. Yeah. So I apologize. I was talking. So I teach for UCLA Health, and I'm one of the lactation consultants there. Actually, I think we refer to you actually.
Oh.
Yeah. So we have a really great prenatal education course for our incoming families. We have about 54 couples per class, and one of the things we have in our curriculum is to teach, therapeutic breast massage and hand expression, just to prepare them for the hospital stay. And especially because there's a certain number of, small for gestational age babies, or late pretermers, or things where hand expression could be useful in terms of making sure there's an effective amount of colostrum being fed to the baby if they're not good feeders. So we teach them prenatally, but I'm somewhat concerned about this whole idea of therapeutic breast massage that we've been teaching. And I want to just make sure that if we're, should we be teaching therapeutic breast massage, or should we be teaching them more like lymphatic drainage massage prenatally? Because lymphatic drainage massage is good for all people, right? Not just breastfeeding people.
Yeah.
Is there a reason to not do therapeutic drainage massage on yourself, for example?
I don't think I mean, they would have a better, I wouldn't just do it on like an average person. I've only ever used it with like radiation, breast lymphedema, or just like breast lymphedema and a large breast after surgery, or these like really large, uncomfortable, engorged breasts. But I would focus, I think, for a mom that doesn't have any discomfort or engorgement on just like doing hand expression. And maybe it's more like getting out the sort of getting away from that idea of, like you said, I remember now when you like the kneading of the breast,
right?
Just that you can like squeeze out milk, and it just like doesn't work that way, you know?
Right. And because what we really want is to stimulate oxytocin and get a good milk ejection. Like that's what we want to do.
Yeah.
And that's hard to do with your hands.
Right, exactly. And instead, I think people start to get like more obsessive about it, when I'd rather just have them focusing on something, that is definitely not going to cause any harm, and like the drainage.
And I now remember where the baby brush thing comes from, and I'll send it to you. But Shelley Marmette, who was like the lactation consultant who actually came up with the field of lactation consultants, she's actually from Brentwood, and she's a speech language pathologist. Her husband was an obstetrician at Cedars, and she's still alive, and she's here. She actually like was kind of the founding mother of lactation consultants. Anyway, so she created the Marmette, technique of manual expression, and it's the baby brush thing is actually in her technique. It's actually part of the protocol.
And I mean, it kind of makes sense. Like they're probably, and they maybe are not even realizing what they're accomplishing, but they're like reducing some lymphedema, and therefore like making the hand expression easier.
Well, and I also think it was about like this more, they would talk about effleurage, like this effleurage touch. It was more important to use a softer touch to try to stimulate oxytocin or to get a milk ejection. Like that was kind of the goal, I think.
Yeah. Whereas now you have like Freedom Mom making these like vibrating devices that like, digging into their breast, and it's like, where did that even come from? Like, where did that come from?
In my presentation on pumps, I have these, they look like vices, and they're these massagers that you're supposed to put on your breast. I mean, it's crazy what they put out there in the market.
Yeah, there's so much. Yeah, it's really quite simple.
So back to prenatal education, what would you want moms to know about breasts? Don't massage the breast. That's one of them.
Probably all those myth busters on my website, like it's not yeast. And I think the easiest way, I think the easiest way to try to, like when I feel like I get the most aha moments with people, is like the vaginal yeast thing, that everyone knows your partner's not going to get a yeast infection from sex. And so like some of that, like trying to just make it analogous, like a baby's mouth, no matter how much yeast it has in it, which it very likely does not have any, that's in any kind of pathologic quantity, is not going to transmit yeast to your breast.
I think there's a lot of people though who, and it's a common thing. Oh, I have a yeast infection and my partner needs to be treated also. And that was very common amongst the Leche League groups, not only do you have to treat your partner, but you treat the baby, you treat the mother, treat everybody in the family, and you've got to bleach everything and use apple cider vinegar and or grapeseed extract on your nipples.
Oh, I didn't realize that people actually think that their partner has to be treated with, it's like, because I dealt with so much vaginal yeast and HIV in Tanzania that, I think, I don't know how else to say it other than like anatomically yeast doesn't occur on the nipple or the areola the same way it like doesn't randomly occur on like your arm if you're so or like someone's so like gnawing on your arm. Like it's just not where it happens.
So for the PT side, a couple of things that I'm thinking is that, one of the things that we get is, we a lot of moms who claim they are having plugged ducts or having reoccurrent problems with plugged ducts. And I know I have sent a couple of patients to rehab specialists for therapy. I don't know, do you guys do therapeutic ultrasound there?
Oh, absolutely. Yes.
Yeah. And so I know that there's been a couple of people we've sent specifically because I think probably because we were giving them bad advice previously, probably like their doctors were giving them bad advice or they were treating them they keep throwing antibiotics at it. And then maybe, so I'm pretty sure that now that we know better, we'll be able to, but I remember learning from Katrina a long time ago about therapeutic ultrasound, and you were the only people that I knew of that were doing it. So therapeutic, that's good to know that you guys have it.
Yes, absolutely. And we have quite a few certified lymphedema therapists on staff as well who do the manual lymph drainage in conjunction. But with that, it's just about 7 o'clock, so I think we should probably wrap up. Dr. Mitchell, thank you so much for all of your expertise. And I'll put quick in the chat, you said your website is physician guide to breastfeeding.org. Correct?
Yeah.
Look good? All right. Thank you so much for coming, everyone. I really appreciate this.
Take care.
All right. Have a great evening. Thank you.